Good afternoon, Peter Goertz. I'm a psychiatrist. Let's talk about first generation or conventional older antipsychotics. When I was a resident in training, psychiatry training, the newer antipsychotics were just coming out. As far as I know, when I first started, there were none available, and then the first one that came onto the market was risperidone, and then a little bit later Zyprexa, and then Seroquel. But initially, we just had, as far as I recall, the conventional antipsychotics. So let's talk about them. Chlorpromazine, which is thorazine, was synthesized in 1951 by Paul Charpentier in the laboratories of Rhône-Poulenc, a French pharmaceutical company, and it was released for clinical investigation in May 1952 as a possible potentiator of general anesthesia. So interesting, the intention initially with thorazine was to use it in anesthesia, and look what happened. Very interesting. In 1952, the surgeon Henri Laborie in Paris used chlorpromazine, and it has antihistamine properties. He used chlorpromazine prior to surgery, and the patients were calm, indifferent. They needed much less anesthetic, and Dr. Laborie then suggested its use in psychiatry. The conventional antipsychotics are thought to be effective via dopamine D2 receptor blockade. There are low-potency conventional antipsychotics, thorazine and Mellaril, for example, high-potency conventional antipsychotics, for example, Haldol, Prolixin. As far as the chemical aspect, thorazine, Mellaril, and Prolixin are phenothiazines. Another older conventional antipsychotic, Navain, is a thioxanthine. Haldol is a butyrophenone as far as the chemical aspect. They vary in potency. The first generation antipsychotics have varying potencies. So thorazine 100 milligrams clinically has about the same antipsychotic efficacy as Mellaril 95 milligrams, Navain 5 milligrams, Haldol 2 milligrams, and Prolixin 2 milligrams. And looking at those that I just mentioned, thorazine and Mellaril are low-potency antipsychotics. Haldol and Prolixin are high-potency antipsychotics. The low-potency antipsychotics tend to cause more sedation, anticholinergic side effects like dry mouth, orthostatic hypotension, which can be a problem with dizziness, falling. The high-potency conventional antipsychotics tend to cause more Parkinsonian symptoms like tremor, which tends to be a 3 to 6 hertz tremor, rigidity, and the Parkinsonian side effects can be addressed or treated with anticholinergic medications like Cogentin. Another side effect that can occur with conventional antipsychotics is what we call akathisia, which is very uncomfortable restlessness, inability to sit still, and propranolol can effectively treat that. Propranolol, which is a beta blocker. Troublesome side effect also is tardive dyskinesia, which generally occurs after longer-term treatment with conventional antipsychotics. Movements like twitching, for example, can occur. Mellaril has an unusual side effect at a dose of over 800 milligrams per day. It can cause something called pigmentary retinopathy. Thorazine can cause cholestatic jaundice. And medicines that are not necessarily used in psychiatric patients or for psychiatric purposes can still have adverse effects similar to antipsychotics or like antipsychotics. For example, the antiemetics compazine, which is prochlorperazine, and Phenergan, which is promethazine, are both phenothiazines. So they're in the same group as thorazine, Mellaril, and Prolixin. And they can both cause, the compazine and phenergan, which are used as antiemetics, they can still cause problems like tremor and tardive dyskinesia. So that can be a rude awakening if someone, for instance, chronically has been taking phenergan or compazine for nausea. Down the road, they may develop twitching due to tardive dyskinesia, for example. The antiemetic Reglan, which is metoclopramide, can affect dopamine and can similarly cause tremor and even tardive dyskinesia. A major problem with first-generation antipsychotics is neuroleptic malignant syndrome, which consists of rigor, so rigidity, fever, autonomic instability, delirium, so a major problem. That generally requires treatment in an ICU setting and mainly needs supportive treatment. Another aspect is partly related to all these side effects I've just mentioned. A lot of patients do not want to take a pill every day of an antipsychotic. And what can help in that situation is longer acting injections. So there are preparations, for example, haldol decanoate, which is given every 4 weeks. And that can be helpful in that the patients do not, in the long run, need to take oral medication, oral antipsychotic medication. They can just get an injection every 4 weeks. Now, of course, those injections can have the same side effects as the oral medications, so it still is a problem related to side effects. However, at least the patients don't have to remember to take the medicine every day. And another longer-term conventional antipsychotic in injectable form, long-term injectable form, is prolixin decanoate, which is given every 2 weeks and has the same principle. The patients may benefit from it if they're not going to take their oral medication every day. Thank you very much.